Hello, everyone. Hello, welcome. Friday the 13th. It's a spooky day here in the holiday season. I'm just joking. Anyways, welcome to CBC. Welcome to all of our applicants who are joining us virtually via Zoom. It's great to have you all join us virtually. It's also great to have a great audience here, a great turnout today for CBC. So today's case is the case of a 46-year-old gentleman, past medical history of hypertension, untreated hepatitis C, and polysubstance use disorder. He presents with numbness, abdominal pain, and melena. And our expert clinician today is Dr. Deborah Parks. Before I talk a little bit more about her, I want to go a bit more about what CPC history is for all of our the new faces watching today. So CPC is one of our most popular conferences where we watch one of our master clinicians reason through a challenging case. This case actually started at Harvard, where they took the concept of case reports from the legal field in law school and applied that to medicine. It then spread there from around the country, and it was first introduced to WashU in the early 20th century by our first chair of medicine, Dr. George Dock, over there on the left. And you can see kind of an example of what this would look like over here on the right in the pits, where we would work, back then, they worked through the cases, and you can see how engaged everyone is, back before the days of cell phones, if you will. So let's go ahead and meet our expert. That's Dr. Deborah Parks. So about Dr. Parks, she's a professor of internal medicine and within the division of rheumatology. In terms of her training, she is almost a WashU lifer. Did a quick stint over in Louisville for medical school, but then did residency and fellowship here. Now we'll go ahead and turn to our case here. So again, our one-liner, 46-year-old gentleman with past medical history of hypertension, untreated hepatitis C, polysubstance use disorder, here with numbness, abdominal pain, and melena. Dr. Parks, please come on up. Please go ahead and give us your thoughts on just this one-liner and how you approach it.
Sure. So first, you cheated me. The one-liner you sent me, you left out the word hypertension. So that's the critical element, right?
Oh, I'm sorry about that.
So again, as a rheumatologist, the first thing I'm going to look at, this is a patient with untreated HCV that presumably got it from his polysubstance use. It's of unknown duration. But in this first line, as a rheumatologist, I'm going to take the fact that he has hypertension, suggesting possible some types of renal dysfunction. He's got untreated HCV, so we know that that can lead to liver dysfunction. It's a risk for hepatocellular carcinoma with end-stage liver disease, risk of portal hypertension. Again, some things there to tie into the GI bleed, numbness, so there's going to be some type of neuropathy, presumably, and abdominal pain and melena. So with that in mind, as a rheumatologist, I'm going to say this is a multisystemic disorder that is likely going to be vasculitis. And if I had to guess, I'm going to say it's going to be cryoglobulonemic vasculitis or PAN. And if we can get to that quickly, I can go to the rheumatology division party, Christmas party that they're having as we speak. Instead of everybody thinks I'm the Christmas Grinch today, so.
Well, I'm sorry to take you away from the party. I'm interested to hear about how those parties go, to be honest. Well, thank you for that initial insight. So let me tell you a bit more about what's going on with this gentleman. So he started experiencing numbness and pain in his hands and feet about 1 month ago. It progressed to complete numbness in bilateral hands within days of initial symptom onset. And what he's noticed, he has difficulty with fine motor skills using his hands. He also started experiencing left lower quadrant pain around the same time associated with loss of appetite, but no other GI symptoms, no dysphagia. Sorry about that. No dysphagia, no odynophagia or anything like that. In the last week, he started having worsening fatigue, malaise, chills, and shortness of breath. And then yesterday, or the day before presentation, excuse me, he had 2 episodes of melena that prompted his presentation to the emergency room. Any thoughts on the case after hearing this?
So again, you haven't told me how long he's had hepatitis C, which I do think plays some role, but this is fairly rapid onset of what sounds like at least a sensory neuropathy that's rapid in onset. It's progressing to frank numbness, and it's clearly sensory motor since he's having some difficulties with this. You didn't tell me whether his abdominal pain behaves like intestinal angina, which would be a key point here in terms of mesenteric vasculitis or even obstructive disease, but he has constitutional symptoms. And again, Many things can cause melena. We don't know, does he have portal hypertension? So he's got splenic sequestration and thrombocytopenia, or I'm still going to bet on vasculitis causing erosions or an ulcer.
Great. Thank you. In terms of the rest of his history, so includes hypertension, hepatitis C is a fairly recent diagnosis, just kind of outpatient workup that figured out about 2 months prior to presentation. Peripheral vascular disease, and then neuropathy, of which we aren't entirely too sure where that started from. But medications over on the right reflect that. So he's amlodipine, lisinopril for hypertension, a statin and aspirin for the peripheral vascular disease, and then gabapentin for his neuropathy. Otherwise, no relevant surgical history, no relevant family history. Allergies are also none. In terms of his substance use, his polysubstance use is actually more smoking in terms of both tobacco and cannabis, occasional alcohol. No overt IV drug use, at least from the records that I could identify here. He currently lives with his girlfriend and he used to work as a cleaning contractor, but has not worked since symptom onset due to his symptoms. Any additional comments at that time, or would you like to see the review systems?
Let's hear the review of systems.
Great. So you can see here, the constitutionally, he's positive for fatigue and chills, but no fevers, no weight loss or weight gain, no night sweats. Other of note is the dyspnea on exertion that he's noticed recently in the last week. I apologize. I think I said no vomiting before, but he actually does have some non-bloody emesis, and then melena decreased appetite. But no other cardiovascular issues, no GU complaints, and of course the numbness in feet, and then some subjective weakness from there too. At least he's like, I feeling fatigue, fatigue versus weakness is unclear based off what he was saying at this time point. So let me ask you now, what additional thoughts do you have after hearing this before we get into the physical exam, vitals of physical exam?
So I'd really like to hear a little bit more detailed review of systems. I'm going to say, I'd like to hear, does he have cold-related symptoms? Again, nothing to suggest whether this was intestinal angina or not, anything to bring out whether he's got more advanced liver disease. So, if I don't get that, I'm going to say, let's look at some labs.
Sure. What kind of stuff are you looking for on the physical exam that would be important to you?
Again, so looking for, even though he was only diagnosed recently, we know that hepatitis C is silent often for many years, and patients may not know they have it. We may not know they have it. So again, looking for things like, spider angiomas. Does he have any, protuberant abdomen, looking for ascites? You've already said he doesn't have mucosal bleeding, but does he have any petechiae, or can he give a history of having rash? Those
Great.
type of things.
Thank you. Okay. Top in. For his vitals, he's initially hypertensive, 154/95, tachycardic as well at heart rate of 131. Rest of his vitals were stable. In terms of his exam, notable for just the tachycardia, but his abdomen, despite endorsing abdominal pain, the notes actually said that pressing on the abdomen relieved the pain more than otherwise. There were no rashes, no spider angioma, petechiae, no pulmonary erythema, no other stigmata of chronic liver disease observed on his skin. And then, as you can see here, this extensive neuro exam. I will say that the neurologist provided this exam, which is the high level of detail we have here. So notable for 4 out of 5 strength and finger flexion abduction, right greater than left. I'd be interested to see if any of our medicine residents have actually tested those skills in our patients. But all other muscle groups are 5 out of 5. He has 1+ reflexes in upper and lower extremities bilaterally. Patchy pinprick loss in hands and feet, but then normal at the more proximal joints there. Decreased proprioception in the right great toe, left is normal. Mildly wide base, but stable gait, but no dysmetria and no ataxia. How do these findings now change your approach and understanding of how you stratify your understanding of this patient's presentation?
So again, it's a distal sensory motor neuropathy, or link dependent. I'm not a neurologist either, but at least, you could use, nerve conduction tests to help you. I think, you would consider whether there's any cervical spine disease as well, but there's a lot of other things going on here.
We'll go ahead and give you the initial labs, the chemistries as well as the CBC, and then we'll do the fun choose your own adventure part too. So his chemistries are remarkably stable, actually. No signs of kidney disease. Creatinine is stable at 0.76. The only thing of note is that his albumin is fairly low at 2.8, but everything else is within normal limits. In terms of his CBC, White count's elevated at 24.9, as are his platelets of 521. Hemoglobin's 14.8. The absolute neutrophil count is 20.4. If you just look at the differential, it's pretty standard for differential, just elevated ANC given the leukocytosis in general, but the diff is actually normal percentages throughout. Looking at this, any other comments before we go to the choose your own adventure part?
So he's hypoalbuminemic, but his total protein's normal. Again, you're going to wonder whether he has decreased synthetic function or is he losing albumin somewhere. And then again, high white count, unusual number of neutrophils. Is this some kind of myeloproliferative disorder, stress leukocytosis, or is something clumping in the Coulter counter making the white count falsely elevated?
So now I ask, what additional diagnostics do you want first? And I will show our next slide here. And here's our selection of options that we can start off with. I was proud I could find a candy cane to stay within the season for our nutrition labs. So after seeing this, when you're talking with your rheumatology fellows or even some of the residents, what do you think would be the first thing that you want answered in terms of your workup?
Well, again, I think if we go back to the last slide, I try and look at things that what are most threatening to life. So supposedly he had melena. So I feel a little relieved that his hemoglobin was 14.8 because otherwise I would want somebody to worry about his GI bleeding first. But going past that, because I try to think a little bit outside the box in terms of not just rheumatology. So in terms of other things that I would like, I would say probably, a lot of things are going to be happening simultaneously. So I would like to get a contrasted image of his abdomen to look at the vasculature. In terms of rheumatology, serologies, I'm old-fashioned. I like to see inflammatory markers, so I'm going to get an ESR, a C-reactive protein. But again, because he's had hepatitis C for unknown amounts of time, I'm also going to ask for checking his hep C RNA. And I'm going to ask the lab to do cryoglobulins. Based on what we see on the imaging, we might want to fluff that out to a much wider differential.
Okay. Well, let's start with the imaging. I do apologize. We weren't able to get a radiologist to join us today, but we got two contrasted studies for him. CTPE showed no pulmonary embolus or other acute findings in his chest. On a CTA, abdomen and pelvis, they saw a few small areas of hyperenhancement in both kidneys, measuring up to 3 millimeters, which may represent microaneurysms. And then some other irregularities here and there, such as the irregularity in the pancreatic head. They recommended MRCP for further evaluation. Some possible foci of pneumobilia, again, indeterminate, may need an ERCP, or given his history, I guess, I don't believe he had an ERCP, but that was just the interpretation from the study from the radiologist. And then his known peripheral vascular disease and the various occlusions seen there, the right iliac, common femoral arteries, and reconstitution of those, which are unchanged from before.
All right, so because again, we don't know about duration, we could say this may be of shorter duration than we may have guessed. We don't know, does he have any risk factors that would otherwise cause occlusion? But when I see an angiogram like this, I start thinking about polyarteritis nodosa, which in the hep C population tends to occur much quicker than mixed cryoglobulinemia with vasculitis, and particularly with the microaneurysms that would concern me.
Great, thank you. So now what's the next ELG? You mentioned looking at ESR and CRP, some complements, cryoglobulins, and maybe some other kind of infectious questions. Where would you want to go next?
Right. So my suspicion for infection, I mean, he's got the hep C, but you want to do due diligence. You want to make sure he's not HIV positive. You want to check hep B, surface antigen and antibodies. And again, with microaneurysms, there's no reason on this guy's exam or anything else to think that he has some kind of, like Ehlers-Danlos vascular. I mean, that would be very far out there and not fit with any of this. But, again, that would be the things that would be going through your brain. We would get an ANCA just to be sure. in this population, we would expect the ANCA to be negative, or we would start being concerned about other types of potential vasculitis. And I'd like to see a urinalysis at some point in this.
Yeah. So let's go ahead and start with the infectious evaluation. So we'll do the initial evaluation. RBP was negative, blood cultures were negative, histo and T-spot were negative. I didn't list it here, but the HIV was also negative as well. And then we can also do some additional. We mentioned looking at hepatitis C, hepatitis B for that. So antibody positive, RNA positive. He had a surface Hep B surface antigen positive, as well as the antibody, a negative E antigen positivity, negative E antigen, positive E antibody, and a DNA titer of 6.7 times 10 to the 9. And then also a positive total IgA antibody, but negative IgM.
So now we know he's got 2 risk factors for PAN. So especially having been here probably longer than many of you are old, we don't see PAN so much anymore. It's pretty rare. But before the days of vaccination for Hep B, but maybe we'll see more in the near future. No, political comment. But that was the major chronic antigenic stimulus for PAN. So my suspicion's still high for PAN.
Great. And then you want to see the room serologies. You mentioned looking at ANCAs. What other antibodies would you also want to check in this patient? You mentioned ANCA to make sure that it's negative. What other antibodies, rheumatologic serologies would you want to check as well?
I mean, he doesn't have joint pain, but again, to help you, because cryos are sometimes not done well, you want to look for a rheumatoid factor as an immune complex, but not because you think he has rheumatoid arthritis. Because it's going to be positive, if it is, you do a CCP just to be sure, but that's really not your suspicion here. You could do an ANA, but I mean, this is not lupus. You're really going after the vasculitic profile.
So let's take a peek at those. His ESR is 55 and CRP was 267. C3 and C4 were within normal, and his cryoglobulins were negative. In terms of the other rheumatologic serologies, his ANA is 1 to 320 in a speckled pattern. A double-strand DNA was 8.0, antihistamines 1.9, and the rest of these tested antibodies were negative. I'm curious, I hear sometimes that some attendings or other doctors are concerned about the pattern of the ANA stain. Is the speckling matter or other patterns matter, or is it more the titers that are important in terms of interpreting an ANA?
So the patterns can sometimes be helpful. So a speckled pattern oftentimes can be helpful for antigens like Sjogren's. That would be the most useful, or a peripheral rim pattern for double-stranded DNA, but the titer is more important. But I mean, ANA of 1 to 320, we would actually consider relatively non-specific. It's a very low positive dsDNA. They do have a positive antihistone, so you start worrying about, is this some drug-induced process? And he did have hypertension. I don't recall seeing hydralazine on his list, but I may have gone past me. But again, when one sees this, I mean, antihistones are nonspecific. There can be overlap with other undetected, even unknown antibodies. So unless there's some other oddball antibody there, we know the ENA panel is negative. So I would say this doesn't really help us other than it's some autoimmune process.
Okay, great. Then you mentioned looking at a UA. Here's our UA. He has a specific gravity 1.025 and a little bit of protein, but the rest of his UA was stone cold normal. Microscopy was normal. They did get a 24-hour urine protein that had 335 milligrams, and they got a UDS at that time, which is positive for cannabis. Does this affect your decision at all? You mentioned you wanted to see the UA. What were you hoping to see or not to see?
So again, I mean, we've not detected a cryoglobulin, but we haven't actually sort of interrogated the lab as to how they did that, because we see a lot of false negative cryos. But in either case, whether this is PAN or cryoglobulonemic vasculitis or some other autoimmune process that you guys are going to throw me under the bus here with, we expect a subnephrotic level of proteinuria, just to suggest there could be some renal disease. The cannabis, you're going to get that on probably 50% of Missourians these days. So I'm not going to tie all that together. But again, this tells me there's some level of proteinuria, and again, harks back to his hypertension and potential renal disease. We know he had some occlusions of vessels. So
You mentioned a bit about interrogating the lab in terms of how the cryoglobulin samples were handled. Can you speak a little bit more about that? Because that's something we will sometimes order, or the rheumatology consults will ask us to order it and make sure that we do that properly.
Correct. So a cryoglobulin to really be run properly, you have to take it down to the lab and it has to be kept warm. So the lab here actually has buckets of warm sand that they'll collect it in. And if the phlebotomist looks at the orders and doesn't really realize that, then they're going to collect it wrong and it's going to precipitate out and you're going to miss it. When I was a fellow, we were told basically draw the blood yourself, stick it under your armpit, and run to the lab with it.
Nice. Back in the day, right?
Back in the day.
Okay. So now where are some of the other testing that you would like at this point? We've have a few other things we can show you. I'm curious kind of where your thought process is and what the next lab or testing that you would want to do.
So I think, again, we probably would call in the troops here at this point. I mean, I think we have an angiogram that's actually fairly highly suggestive. We would love to have tissue if we could. That gets a little bit harder with what we've seen so far, but we could get additional imaging of the kidney. We didn't really see much, I don't recall, on the CT, but I would probably get nerve conduction testing to better characterize his neuropathy, to see if that actually was sensory motor, to see if there's anything amenable to a nerve biopsy. That would be another possibility. Again, we know he had some bleeding. Don't recall if we ever saw a protime. So again, underneath the bleeding workup, whether he had anything else there to contribute to his melena.
Sure. So as anyone who comes in with melena, we consult GI appropriately, and they come and see him. In the meantime, we're getting him scheduled for the EMG and nerve conduction study. So in terms of the bleeding workup, they got a ferritin that was elevated to 1800. His anticoagulation, the PT, INR, and PTT were all within normal limits. On the EGD, showed gastritis and duodenitis with multiple non-bleeding clean base ulcers in both regions, but no actual evidence of active or recent GI bleed on when he was scoped a couple day or so after he presented. They took a biopsy that was negative for H. pylori, and so they concluded that findings were suspicious for NSAID-induced ulceration. And on further questioning, he was using some NSAIDs prior to this.
And he was using them for what? Because you said he had no arthralgias, just his numbness?
Yeah, he was trying to see if that would help, and it didn't really help too much. But and then lastly, got a colonoscopy, which showed aphthia throughout the terminal ileum and examined colon. Biopsies for that were actually negative for any significant abnormalities, and those findings were consistent with enterocolitis.
And were those sent for cultures or any GI studies to look for things like CMV?
No, those were not.
Okay.
Everything was negative, so I presume that they didn't see any inclusions or anything consistent with CMV on the biopsies.
So his ferritin's consistent with an acute inflammatory process or liver disease. We can worry this is at a high enough level that we start worrying about systemic inflammatory syndromes. The ulcerations themselves, so in terms of vasculitis, I'm just going to throw out there, you're never going to get the diagnosis from a mucosal biopsy, or it would be incredibly rare. So that does not exclude a vasculitis. The aphthia in the colon and ileum also could be of that nature. We could throw out there, we haven't had any other history to suggest something like Behçet's or an inflammatory bowel disease, but again, could there have been some infection as well?
Yeah, great. Well, then the next thing you said is in terms of trying to get the EMG and nerve conduction study. So that's not the slide I wanted. Whoops, it quit. Here we go. So we got an EMG nerve conduction study that was finally done. It showed I'm not going to show through all of the exact numbers because I don't expect any of us to interpret that, but our great friends in neuromuscular, in the neuromuscular division, said it's variable and asymmetric involvement of different nerves in the upper and lower extremities with sensory and motor deficits consistent with polyneuropathy multiplex.
In all four extremities.
Correct.
Yeah. Okay.
How does this help you in terms of your understanding?
I think he's got vasculitis. Great. I'm going to harp on that. I think he's got PAN.
Okay.
But you could do a nerve biopsy if you felt strongly that you needed the tissue biopsy.
The team did feel strongly, and we have Dr. Brendan Crumley, is a fellow neuropathology who is here to talk us through some of the slides here.
All right, so we got both a muscle biopsy of the right vastus lateralis and a nerve biopsy of the right sural nerve, and the most significant findings are actually in the muscle biopsy. So on low power, we can see what we call fiber size variation. That's a pretty non-specific finding. To paraphrase what one of our more seasoned attendings says, if you went out on Euclid and muscle biopsied 100 people, you'd probably find fiber size variation in every single biopsy. So that doesn't really tell us anything. But then if we go to this vessel right here, it's even kind of hard to see it's a vessel at low power, but it's surrounded by an inflammatory infiltrate. We don't see too much else with the muscle. There's no necrosis, no significant features of myopathic or neuropathic change. And I'll go ahead and also say that we didn't see very significant pathology in the nerve biopsy. We did see a loss of small and large myelinated axons, but in and of itself, that doesn't point to a specific diagnosis and is fairly nonspecific. And so going on to higher power, we can see even better that this vessel is just completely surrounded by both what look like both lymphocytes and histiocytes. The lymphocytes are the smaller dark blue cells, and the histiocytes are right about here, the larger cells that look a little bit more polymorphic. And then we have the endothelium right in the center, and there's a suggestion of vascular damage on H&E, but we like to evaluate that with immunohistochemistry to say for sure, and I have a slide on that in a little bit. And then on high power, even higher power, we get a better image of the inflammation to the vessel. We did not see this sort of inflammation in the nerve biopsy, but depending on exactly where in each nerve and muscle the sample was taken, you may or may not see vasculitis in all of your samples, or inflammation, sorry. And so the first immunostain we did was SMA, which helps us characterize the integrity of vascular walls. And here we can see some partial disruption of the vascular wall that's involved by the inflammation. And to characterize that inflammation, we did several immunostains for various hematopoietic cells. And we can see that the infiltrate is composed primarily of CD3 positive T lymphocytes and CD68 positive histiocytes, which led to a diagnosis of skeletal muscle with lymphohistiocytic vasculitis. We also did a stain for CD20, looking for B cells. We always like to rule out intravascular lymphoma, but we did not see anything. And you mentioned Dr. Parks' PAN on your differential. I spoke with one of our renal attendings who handles a lot of renal vasculitis cases. He said these findings could be compatible with PAN, but they aren't definitive one way or another. And he would issue the sentence that pathologists and radiologists love to say, correlate clinically.
Thank you so much, Dr. Crumley, for that information. And clinical correlation is obviously very important for all that we do, especially I think even within rheumatology, where it's the constellation that really sells it. So, Dr. Parks, I think at this point, do you have any final thoughts on this case? And unless and do you think you can give us what you believe the diagnosis is in this patient?
Unlike a broken record. So, I mean, at the end of the day, it's a clinical diagnosis, right? But you put it together, you have somebody who's had chronic antigenic stimulation for at least a while with both Hep B and Hep C. You've got ulcerations, you've got microaneurysms and occlusions, you have subnephrotic proteinuria, and you have, I'll call it polyneuropathy multiplex. That's vasculitis in my book.
Great. And what kind of vasculitis do you think this is?
This is a medium to small vessel vasculitis. So again, that puts it more in the PAN category, but we can just call it medium vessel vasculitis. But
great.
Yeah.
Great. And so he did end up having immune-mediated mononeuritis multiplex secondary to polyarteritis nodosa in setting of active hepatitis B. Thank you so much. bit more about his hospital course. So in addition to neurology, he actually ended up going to neurology service, and they were doing a lot of the neuromuscular workup and the other aspects. But they also got hepatology and ID, were consulted for management of active Hep B, given his need for immunosuppression. They started him on entecavir for treatment, and then they did Plex ×3, as well as high-dose steroids, IV steroids, followed by PO, with improvement in his paresthesias, and he was discharged on a steroid taper. He actually never followed up with neuro or rheumatology, but he has been seeing GI/hepatology regarding his Hep B and Hep C treatment since then, and also has been seeing follow-up for his peripheral vascular disease as well. So I'm going to talk a little bit about polyarteritis nodosa, or at least as best as possible, given my understanding of it. So like Dr. Parks mentioned, it's a median vessel and small vessel arteritis that can affect the muscular arteries in virtually any organ. And so it can present in a bunch of different ways, of which several of them actually manifest in our patient. So neurologic manifestations include asymmetric polyneuropathy or mononeuropathy. Seen here, they say like affecting the name nerve. This is things like your radial nerve or tibial nerve, things like that, as one of the most common findings. More rarely, they have CNS disease. GI includes abdominal pain from mesenteric arteritis. It can vary from not just simple nausea, vomiting to life-threatening bleed, myalgias, weakness. Skin findings are also pretty common. However, our patient did not have any of these. And then the renal arterial aneurysms. I will say that actually on the read for the CTA, it did say suggestive of polyarteritis nodosa, but I decided to withhold that information to have a little more fun with you. Not like it really mattered because you got it from the beginning. And then other various manifestations: orchitis, ischemic retinopathy, lung manifestations, and even splenic infarction. In terms of diagnosis, like mostly everything in rheumatology, there's no specific lab or symptom is sufficient to diagnose. It's really the constellation of patient history, physical exam findings, laboratory imaging, everything, biopsy works, all put together. Hepatitis B is, I think, more of the commonly associated ones, at least for our residents and medical students. I think that's the one that they tend to associate when you take your shelf. However, hepatitis C, IV drug use, even prescription drug use can all predispose you to polyarteritis nodosa. Any physical exam findings consistent with the stuff we mentioned in the previous slide. In terms of labs, it'll be important to rule out other autoimmune causes such as ANCA vasculitis, because if there is a positive ANCA, then that would not be associated with PAN. Biopsy can be helpful. They have to be careful which biopsy you pick, and as we saw here, the biopsy is not always a nice slam dunk that we like it to be. And then the arteriography, like Dr. Parks wanted at the very beginning, showing those microaneurysms and any irregular constrictions can be suggestive as well. I do want to point out that ACR guidelines actually recommend nerve and muscle biopsy over just nerve biopsy for patients with suspected PAN and peripheral neuropathy, which is what happened with our patient. Treatment strategies. I was reading through this, and I kind of hope that Dr. Parks, you may be able to speak a bit more to this. My understanding, at least from reading around, is if there's concurrent viral infection, the decision to treat PAN versus infection kind of depends on the severity, which really is there organ or life-threatening disease or not? In general, if it's not severe, you can favor starting antivirals. However, in what I read, if there are signs of mononeuritis multiplex, then that would be considered a more severe presentation. But in this case, they decided to favor treating the hepatitis B first prior to treating with immunosuppression. And then let me finish off the slide, and I can ask more for your opinion. In terms of immunosuppressive regimens, it's usually steroids, IV versus PO. The more severe, you get IV. Cyclophosphamide, methotrexate, or azathioprine for non-severe or for maintenance after cyclophosphamide. And then lastly, there's a question mark about the efficacy of Plex, which was used in our patient, but in terms of efficacy for all patients remains to be determined. Dr. Parks, can you speak a little bit more to the treatment for PAN and how kind of these different decisions and how you would pick one for the patient?
Sure. So again, because I'm old, I can speak a lot on back in the day when we didn't know these viruses were driving this process, treating them with immunosuppressive therapy, and it was ugly. So anytime we can treat the underlying viral process in milder disease, sometimes that's enough. In this patient, he already had vascular occlusion, he was getting renal involvement, he was having GI bleeding. But again, the GI bleeding wasn't so severe that he was profoundly anemic. The neurologic manifestations, I wasn't there, and he had weakness, but it wasn't complete wrist drop or it wasn't complete foot drop. So at least trying to get a head start with antiviral therapy and plexing to try and pull off immune complex to start out with, and then withholding cyclophosphamide for 2 to 4 weeks wouldn't be unreasonable.
Quick question about that, following that wonderful case, beautiful presentation. That is usually superb on-target analysis. Given that this patient is receiving both an antiviral therapeutic approach as well as an immunological approach, given where his condition is at the moment, how would you assess his prognosis? What's going to happen to him if he's able to stay off insulting drugs?
Before you answer, I just want to say the question was kind of assessing this patient's prognosis given his presentation and treatment if he adheres to that.
So the best you can hope for this gentleman, you're not going to make the occlusions go away, right? So ischemia in his GI tract is going to be a lifelong issue, but hopefully you can help where he has impending lesions or where he has ongoing active disease, preventing renal ischemia so he doesn't develop renal failure. So you're going to be following all those organ systems, and hopefully what he actually stands the most to gain from all this is some recovery of weakness. So no matter how profound, I mean, I have seen people recover. And again, I don't know what was chosen. I probably would have chosen oral cyclophosphamide myself, but many of my younger colleagues, it makes them very anxious because they just don't have as much experience. Again, this is the one disease that we're not using what tends to get called vitamin R, Rituxan. And so again, cyclophosphamide, those of us who are older and have more experience with, are more comfortable using.
Well, thank you so much, Dr. Parks, for an excellent discussion. Thank you all for coming.